come to surgery and surgical procedures. If, despite all efforts, curvature continues to increase and the degree of curvature exceeds 50 degrees according to Kopp, surgery is generally recommended. However, we need to ask ourselves why surgery is recommended and what are the benefits for the patient. In late onset, so-called adolescent idiopathic scoliosis, surgery is not necessarily indicated from a medical standpoint, and to date, there is no scientific evidence to support the hypothesis that the resulting health outcomes of untreated scoliosis are worse in the long term than the health outcomes of those who have undergone scoliosis surgery. It has been shown that such curves do not usually become so large that life-threatening limitations of the cardiovascular systems are to be feared. There is also no correlation between Kopp angle and pain. Therefore, for these patients, there must be another reason why they would choose to undergo surgery for a Kopp angle greater than 50 degrees. If a patient perceives scoliosis as a deformity that causes psychological distress, depression, anxiety about the future, and perhaps a decreased quality of life, then it is possible to do something about it. It seems that it is not purely medical reasons, but the psychological viewpoints that determine the outlook. If there is no motivation for physiotherapy and orthotics, then there is no other therapeutic option for treating the deformity other than surgery or doing nothing. According to the findings of health psychology, psychological distress caused by the deformity can also lead to physical complaints. There is no doubt that scoliosis surgery is not a purely cosmetic procedure. However, in this 14-year-old patient with a bone age of 14.9 years, 98.8% mature, angle of curvature, thoracic, 43 degrees, lumbar 32 degrees, without significant cosmetic impairment, satisfied with her appearance, there is absolutely no indication for surgery. An urgent indication for surgery was determined by a spine surgeon. Prognosis: for this patient, there will be only a slight tendency for progression even without therapy. No significant cosmetic deterioration is expected in the long term. In the rarer cases of early onset curvatures and in some cases of congenital spinal deformity, which can be quite pronounced even in early infancy, early surgery is justified for purely medical reasons, as the prognosis is much worse than in an adolescent idiopathic case. This may also apply to a subset of children with nerve and muscle disorders and the often severe spinal deformities resulting from these underlying conditions. However, a Cochrane review found no evidence of benefit from spinal fusion surgery for neuromuscular scoliosis due to Duchenne muscular dystrophy. What surgical options are available? A basic distinction is made between posterior and anterior approaches. Let's have a look at the posterior approach first. In the posterior approach, the scars are located in the midline of the back and it is not uncommon to have an additional scar above one of the two iliac crests. Several rod systems are currently used for this procedure. They are attached to the spine with hooks or almost exclusively today with screws and thus span large areas. For better stabilization, these rods can be made with various cross connections to prevent any mobility in the spanned spinal region immediately after surgery. This promotes subsequent bone strength using the patient's own bone material deposited during the surgery. Patients undergoing posterior spine surgery can usually leave the hospital as soon as the sutures are removed, but no later than 14 days after surgery. However, the disadvantage of this approach is that more spinal segments must be fused than with the anterior approach. So now let's have a look at the anterior approach. The anterior approach is not in the center of the trunk. The incision is usually made more laterally along a rib. The rib is removed and, after being cut into small pieces, is later placed in the intervertebral spaces as an autologous bone material for fusion. After opening the chest and/or the abdomen, the spine is exposed anteriorly. This technique allows the surgeon free access to the vertebral bodies and discs from the front. For the correction procedure, the discs are removed from the selected area and screws are inserted into the sides of the vertebra to be corrected. These screws are connected to a rod and fixed to it after the correction. In place of the removed discs, the prepared bone material harvested from the patient is used. In the lumbar region, this is sometimes additionally supported by small metal cages which are better able to maintain the space of the disc. This can prevent the development of a lumbar kyphosis. If the size of the vertebral body allows, modern surgical techniques use two rods for better initial stability in the anterior approach. The disadvantage of the anterior approach is the need to open the abdominal and/or thoracic cavity for access. The undeniable advantage of the anterior approach is that fewer vertebral bodies are involved in the fused area, resulting in better residual motion and trunk function after surgery. In addition, rib hump and lumbar prominence can be better reduced immediately after surgery with an anterior approach. A posterior approach usually requires additional cosmetic surgery on the ribs to reduce the size of the rib hump. Another advantage of the anterior approach is that the scar is less visible. It is largely hidden under the arm at rest and is not even visible when girls and women are seen from behind in swimsuits. This picture shows the radiologic result of a 16-year-old girl with straightening of the curvature from 68 degrees to 14 degrees, according to Kopp, operated from the ventral approach. The lateral profile was also lengthened and the kyphosis, which was more pronounced than normal in the transition area between the thoracic and the lumbar spine, was also straightened, as seen in the lateral images. Both anterior and posterior versions of this procedure are now standard in specialized spine centers. The choice of which procedure to perform is determined solely by the degree of curvature, the pattern of curvature, and the rigidity of the curvature, not by any limitation on the part of the surgeon. A 14-year-old girl with idiopathic double curve scoliosis. Prior to surgery, the thoracic curve was 54 degrees, which was almost completely corrected after surgery using the MPDS instrumentation through a posterior approach. The lateral profile of the spine was also positively affected by this surgery. A severe spinal curvature of 112 degrees prior to surgery, performed on the same day using a combination of anterior and posterior approaches. Straightening to 28 degrees is significant and not possible with either instrumentation alone. In conclusion, the anterior approach is the more cosmetically pleasing and functionally less restrictive option. The overall short-term risk of surgery for adolescent idiopathic scoliosis is approximately 5%. This means that 95% of patients can leave the hospital without complications, usually within 14 days. Complications which occur in about 5% of surgeries can be classified as follows. Inflammation, which can usually be controlled with antibiotics. Adverse respiratory effects due to postoperative bleeding, which can usually be alleviated with appropriate suction drainage. Rod, hook or screw fracture or dislocation, which may require revision surgery. Neurological complications in less than 1%. In most cases, postoperative paralysis resolves and only a handful of patients experience permanent nerve damage. This means that surgery for idiopathic scoliosis is associated with relatively few complications in the short term. However, in the international literature, authors have reported the possibility of postoperative pain occurring several years or even decades later, as well as a not insignificant number of patients requiring repeated follow-up surgery due to late complications. In a publication on the long-term results of the Cottrell-Debussy procedure, it was reported that almost half of the patients required repeat surgery within 20 years of follow-up. Recent review studies are beginning to show that people are more likely to have long-term problems after surgery than after no treatment at all. Scientifically, there is no medical indication for spinal fusion surgery in scoliosis patients. This has been found in 2 Cochrane reviews, which are unbiased reviews conducted by the Cochrane collaboration, and in other systematic reviews as well. In addition, patients should be made aware that the clinical corrections achieved by spinal fusion surgery are not necessarily stable. This is a late outcome after spinal fusion surgery, and the correction as seen on the radiograph on the left can be considered above average, but the rib hump has reappeared 5 years after surgery as seen on the right. Recent non-fusion developments such as vertebral body tethering, VBT, and ApiFix appear promising at first glance, but long-term results are not yet available, and the immediate risk is currently still high because the learning curve for spine surgeons using these procedures has not yet reached its zenith. Patients considering surgery should inform themselves fully about the available options and only consult well-known and experienced spine surgeons. Unfortunately, there is insufficient quality assurance in this area. It is even possible that otherwise the cosmetic appearance may even deteriorate as a result of poorly planned surgery.